Hello students, this is Mrs. Popplewell again, and we're going to talk about joints of the skeletal system. Now joints form where two bones articulate with one another. It makes bone growth possible, and we talked about that in the last chapter, permits parts of the skeleton to change shape during childbirth, enables the body to move in response to muscle contractions. Now, joints are classified by two different ways, and one is functional in the amount of movement allowed. Some vocabulary here: synarthrotic or synarthrosis means that the joint is immovable. Amphiarthrotic or amphiarthrosis means it's slightly movable. And diarthrotic or diarthrosis means it is freely movable. The suture lines in the skull are synarthrotic, is represented, or an example of synarthrosis. It is immovable or essentially immovable joint. The intervertebral discs, two vertebrae together, move oh so slightly. Your vertebral column and your full range of motion of your spine is basically due to slight movement between two vertebrae, and that is called amphiarthrosis or amphiarthrotic joints. A diarthrotic or multi-axial joint is like the hip joint and the shoulder, ball and socket joints, the joints in your fingers. It allows for movement in several directions and free movement. Then you have structural types of joints, which is another classification of joints. Or fibrous joints, where you have dense connective tissue connects the bones. Between bones in close contact, there is usually no joint cavity, or there is no joint cavity. Cartilaginous joints, where hyaline cartilage or fibrocartilage connect the bones, there is no joint cavity. And synovial joints, most of the joints in your body are synovial joints, and they are the most complex joints and allow for free movement. Fibrous joints, there are three types. Syndesmosis. Syndesmosis has long fibers, connective tissue that connects the bones. It is amphiarthrotic. The distal ends of the tibia and fibula, here's the tibia and the fibula, and this fibrous here is connective tissue that allows for just a tiny bit of movement between those two bones. A suture joint, by the way, there's one of those wormian bones that we talked about in the last chapter. The suture joint is between two flat bones. It's synarthrotic, no movement. Now, one exception there would be where an infant has fontanelles, and as they're being born, those plates in the skull will give just a little bit, maybe even slide past each other just a little bit to allow for movement through the birth canal. But when those joints fuse, they become synarthrotic. It also involves a thin layer of connective tissue that connects the bones. Okay, and this is sort of pulled, that suture line sort of pulled apart, and so that's how that bone or that joint is fused. Now the next one is a kyphosis. It is a cone-shaped bony process in a socket. It is the tooth and the jawbone, and the mandible and maxilla, your tooth and the jawbone, and hopefully it's synarthrotic or immovable. A peg in a socket. Now, we just talked about this a minute ago, the newborn skull. The fontanelles of the newborn allows, these joints are not totally fused yet, and so it allows for a little give between these plates, these bone plates, in the process of birth. But then that fontanelle should be totally gone, and these joints will become totally fused by age 6. Cartilaginous joints. Hyaline cartilage and fibrocartilage are cartilaginous joints. There are 2 types. Synchondrosis, there's that word, that part of the word that we know it has to do with cartilage. Synchondrosis and a symphysis joint. Synchondrosis is where you have bands of hyaline cartilage unite bones. It's between the manubrium and the first rib is a synchondrosis joint. Okay, it's immovable, synarthrotic. The growth plate in a young long bone is temporary, and it is synarthrotic. And I just want to point out here, since we have the rib cage here, this is a synchondrosis joint, and these joints, the rest of the ribs, are considered synovial joints, which is interesting. Allows for this little bit of expansion of the rib cage as a person takes a deep breath. Then we have another cartilaginous joint type is a symphysis joint. It's where you have pads of fibrocartilage between the bones. The symphysis pubis, joint between the bodies of the vertebrae. It is amphiarthrotic. It allows for a little bit of movement. This joint is not a synovial joint. Okay, it's only slightly movable. Now, in the pelvis, these are the pubic bones in the front pelvis. This allows for a little give in that pelvis if you're playing touch or tackle football, or if you're in a car wreck, if you're giving birth to a child, or that tilt of a little girl's pelvis whenever she reaches maturity and reaches puberty. The hormones allow for just a little bit of give in this pelvis where you have pelvis tilt. We talked a little bit about that. The distance between the ischial spines of the pelvis in an older female is a little bit different than a male because of this little bit of pelvic tilt that happens. And that little bit of give happens because of that symphysis pubis joint. Okay, then we have those cartilaginous or fibrocartilage pads between the vertebrae. And I'm going to go to the next slide and talk about this. Now, this is my x-ray. A couple of years ago, I had 3 cervical vertebrae fused. And I was amazed because I still have pretty good range of motion. I drive or pull a trailer and sometimes have to back a trailer, and it takes practice and to be good at backing a trailer. And you have to look over your shoulder to look behind you. You have to look in the mirror, the side mirror, and concentrate on what you're doing. And I am still able to do that because the movement between 2 vertebrae is amphiarthrotic. Very little movement is allowed. It is the collective movement of all these vertebrae that allow for the full range of motion of the neck and the spine. Now, synovial joints, most joints in the body are synovial joints. Their articulating surfaces are separated by a synovial fluid-filled cavity. It allows for greater freedom of movement. Then here's the structure. You have the bone and then the joint capsule, articular capsule here. Then you have a synovial membrane. That synovial membrane actually produces the synovial fluid, and it allows for the reabsorption of the fluid, or when needed, making of more fluid, and it's sort of circulated through there. And also you have phagocytes found there. Remember, phagocytes play an immune response if that bone is injured or there is infection. Then the phagocytes can help combat that, the inflammation and microorganisms from an infection, and then they can be reabsorbed. And anyway, so that is the job of that articular capsule, or the synovial membrane here. And then you have bursa. This joint capsule helps to hold the synovial joint together by ligaments binding articular ends of the bones together. You have connective fibrous articular joint that fuses to the periosteum. So this helps. Remember that ligaments bind bones together, so you would have ligaments holding this joint together. And where you have that articular capsule and those ligaments attaching that bone to bone in that joint, they're actually fused to the periosteum on that bone. They're like continuous with one another, and we've talked about this before. If you rip that ligament away from the bone, you usually bring bone with it. That would be the same for those muscles that are attached to the bone by a tendon. Ligaments and tendons are fused to the bone. They're like part of the bone. So if you rip it away, you're going to bring bone tissue with it. So ligaments provide strength and support. Bursa and tendon sheets associated with these joints are like bags of lubricant that reduce friction. Bursa are flattened, fibrous sacs lined with synovial fluid. Bursa is common where tendons, ligaments, skin, or muscles rub against each other. An example would be patella. When we talked about in lab about sesamoid bones, or with the skeletal system, sesamoid bones are round bones. They're found where you have all these together, and they help to separate out those ligaments and tendons and reduce friction between them so they don't rub against each other so much. Intermembranous. Articular cartilage that we see here is avascular. Remember, that means without blood vessels. Anytime a tissue is avascular, if it's injured, it is very difficult to repair, and also that synovial fluid is going to have some nutrients in it, and then those phagocytes and everything, and so it provides this tissue with nutrients and things that it needs, because that hyaline cartilage or articular cartilage is avascular, and it provides oxygen and all that's needed by the living cells in the area. That synovial membrane secretes synovial fluid, surrounds the synovial cavity. Also, it doesn't really show this. This is a picture out of the OpenStax books that is very, very simplified, but we should see a little bit of adipose tissue here. So you're going to have a little adipose tissue in that joint. And I did mention that it's able to reabsorb and make new, remove substances from an infected joint cavity. Bursa, fluid-like sacs that we just talked about, that serve to prevent friction between the skin, muscles and tendons, and underlying bones. 3 major bursa in joints and flat pads or part of the complex joint that unites the femur and tibia in the knee joint, the most complex joint of the body. Now, types of synovial joints. The first one is going to be the ball and socket joint. It allows for most possible movement, rotation in all directions. And by the way, another type of ball and socket joint is the shoulder. The shoulder has more range of motion than the hip. You see the hip here. By the way, most hip fractures occur, and this sounds like a good exam question or quiz for lab. Most hip fractures occur at the neck of the femur. All right, but anyway, if you looked at the number of ligaments that hold this joint together, there's one main one that holds that ball of the femur into the acetabulum of the coxa, but there are many, many layers of ligaments that hold the head of the femur into the acetabulum of the coxa. And because of all those ligaments and the very heavy joint capsule, this ball and socket joint will have less range of motion than the shoulder joint, which is also a ball and socket. Then a condyloid joint is the joint between the metacarpals and the phalanges. Here's the carpals, metacarpals, phalanges. Phalanx is singular, phalanges is plural. Okay, just a little review for lab. This is a proximal phalanx because it's closer to the body, and the distance away from the body would be the distal phalanx. Notice this one only has two. That's the thumb. It is missing the middle or intermediate phalanx. Okay, the joint between the metacarpals, the palm of your hand here, the metacarpals and your finger, the proximal phalanx, that joint is called a condyloid joint because it's sort of concave and convex together. It allows rotation in all directions, just like that ball and socket joint, with a little bit less flexibility. Condyloid joint. That you need to know that for lecture and for lab. All of this stuff. Okay, other types of synovial joints. There are 6 types here. Pivot joint allows for rotation around an axis, such as between the first and second vertebrae. Remember the names of the first and second vertebrae? The C1, C2, the atlas, and the axis. Which, by the way, there's very little movement between the atlas and the axis. It is the collective movement of all the cervical vertebrae that gives you the ability to move your head from side to side. 2 flat surfaces provide a plane joint. We're not there yet. The hinge joint, the elbow works like the hinge in a door for flexion and extension. Now let me say this right now, that in lab, not so much in lecture, but in lab, you're going to be asked for the action of muscles. When you give an action of muscles, it is usually, unless it's working with synergy, that's when 2 muscles are working together for the same motion, you are going to only move that object in one direction. With joints, it's 2 or more directions. Okay, so a hinge joint allows for flexion and extension. Flexion and extension. Now, the elbow is a hinge joint between the proximal, intermediate, or middle phalanx and the distal phalanx, those are all hinge joints, flexion and extension. That condyloid joint between the metacarpal and the proximal phalanx gives a little bit more motion. It between the radius and the ulna, or the carpal bones of the wrist, you have a condyloid joint also. Okay, hinge, flexion and extension. Now that muscle may, like the biceps brachii, that would be right here, the triceps in the back. Okay, anterior upper arm, you're going to have that biceps brachii. Its action is flexion of the forearm, and that's it. By the way, on your practical, make sure you're mentioning what body part is being moved, okay? Flexion of the forearm. Now, the triceps brachii's action is extension of the forearm. Don't mention both, okay? But a hinge joint, flexion and extension. Articulation between the trapezium carpal bone and the first metacarpal bone at the base of the thumb is a saddle joint. Okay, so it's hard to see on this particular picture, but okay, so between the metacarpal and the proximal phalanx is going to be condyloid. But if you go to where that between the trapezium carpal bone and the first metacarpal bone, okay, right there at the wrist, the base of the thumb, it is called a saddle joint. It allows for that pinching of the fingers, putting the first index finger and your thumb together. That pinching motion is very important for function. And that motion, giving us our dexterity, separates us from a lot of animals, allows us for fine movement of our hands to grasp things, and the saddle joint allows us to do that. If you were to lose the use of that thumb and you don't have that pinching motion, for one hand is like 25% disability, for the other hand would be 25% disability. That's a pretty major percentage of disability, because that articulation of the saddle joint and pinching those fingers together to grab things is very important. Okay, plane joints, such as those that between the tarsal bones of the foot and some of the carpals, they allow for limited gliding motion past each other. Okay, the carpals and the tarsals, two flat surfaces that sort of glide just ever so slightly past each other. And again, there's that condyloid joint again, the radiocarpal joint of the wrist, and the condyloid joint is a condyloid joint, and between the metacarpal and the proximal phalanx is a condyloid joint. The hip and shoulder joints, of course, as we've already said, is a ball and socket joint. There's that gliding joint. This is just the last slide was from the open stacks. These are older slides, and those are the carpals there. And just very, they're amphiarthrotic, very little movement between those. And then you have the hinge joint, the elbow, that allows, now your knee is also a hinge joint, but we call it a modified hinge joint because when you're in the orthopedics office and they are looking at your knee, they will bend it and they will slightly rotate to see how much rotation you have in that knee. Too much rotation means that you have a problem. Okay, so there's slight rotation in that knee. It's considered a hinge joint, but we call it a modified hinge joint. Okay. The humerus and ulna, we already talked about that in the elbow. The pivot with the radius and ulna is also a pivot. Between the radius and the ulna, and between the atlas and the axis. And this is called the dens, where the atlas articulates ever so slightly with the atlas. Okay, and this is a posterior view because that's the spinous process. It's bifid. Remember, bifid means fork. That's the characteristic of cervical vertebrae. And those transverse foramen, also a characteristic of a cervical vertebrae. And you learned that hopefully in lab. So this is a pivot joint. And we just talked about the saddle joint. Here's a larger picture of the bones of the hand blown up between the carpal and the metacarpal of the thumb. Okay? So this is actually a metacarpal. And then there's that condyloid joint. Remember that the thumb only has 2 phalanges. That's a condyloid joint. This is the palm of the hand, remember? And then right here, this is going to be important if you have to label this in lab to know and realize where that saddle joint is. But again, the pinching of those, or placing the thumb and the fingers together, that pinching motion is allowed by this saddle joint, which makes us separated from other animals because of our dexterity. Now, type of movements. I'm going to talk about these. You ought to practice these at home because you don't see me doing these motions. But abduction, adduction. Now, movement away of a body part away from the midline is called abduction. Putting it back or adding it back to the midline is adduction. There's dorsiflexion and plantar flexion. Now, plantar flexion is pointing your toes like you're doing gymnastics or springboard diving or ballet. You're pointing that toe. That's plantar flexion. And then dorsiflexion is actually bringing the toes closer to the trunk. So bringing the toes up. Plantar flexion, pointing. Dorsiflexion is bringing the toes up. I may have already mentioned this before, but when you have a joint is immobilized for a long period of time, it loses some function. If a person is in a coma, if a person is experiencing a brain tumor or such, or a stroke, sometimes they lose dorsiflexion because as the baby or the fetus is growing in the womb, everything's pretty much flexed. It's in flexed position, and this is the natural position, flexed position of the body. It takes commands from the nervous system for dorsiflexion. It takes work for dorsiflexion. So if a person is in a coma or bedridden for a long period of time, then they may lose the ability to raise that foot. It is called drop foot. So what that caregiver or family member, person who cares about that individual in that coma or in a bedridden state, should put like high top tennis shoes on this person, or sometimes they put a brace. Now, what they have to worry about with a brace is that contact, if they're not mobile, then, to move around, it increases circulation. So circulation is compromised, and ulcers can often happen when you put the tennis shoe on too tight or with a brace or something. So maybe a sock and a tennis shoe to keep that foot up. If they get drop foot, that's one of the hardest things to return from after a stroke or in rehab, the removal of a brain tumor, or rehab after being in a coma, or that leg being immobilized for an extended period of time. And so that is a concern. Here's flexion and extension. Now you have flexion and extension in this hip joint, and then flexion and extension in the at the knee. Now let me say this. When you get to your muscles, you have to know the origin, insertion, and action of those muscles. And I just told you that muscles only move in one direction. It gets confusing when you look at your lab manual or you look at your list and it said this muscle flexes and extends. Wait a minute, Miss Popplewell, you said it only goes in one direction. But what it might do is flex at the hip, but also extend the lower leg at the knee. So it does both of those things. Okay, and some muscles work in synergy as they're working in a group. They like kicking a football, kicking a ball, you have flexion at this joint and then extension at the knee. Okay, rotation, circumduction. Rotation is the movement allowed in the shoulder joint, allows you to turn your total arm, your thumbs down and then back up again. Circumduction is doing circles with that hand. Pronation is thumbs down. Supination is thumbs up. Remember, the correct anatomical position of the body is thumbs up. When you turn that thumb down, that's called pronation. When you bring it back up, that is called supination. And by the way, that rotation is called or described as the limb moving around an axis. Okay, so some other joint movements. Eversion, inversion. Now inversion's turning that ankle inward, which we do a slight bit of normally, and turning it outward where we don't do a whole lot, very little movement as you're moving that ankle outwards. Okay, a forced inversion will pull on those ligaments, twisting your ankle. We'll pull on those ligaments, and ligaments do not have good memory. What does that mean? Ligaments, when stretched, tend to remain stretched. You twist that ankle once, it's going to be easier to twist it again, and if you twist it several times, it's going to become more easily twisted, and you're going to have a weak ankle. Now, we usually can get over. Now, forced inversion is going to tear stuff and can cause permanent damage that may even require surgery. Eversion, though, forced eversion, usually breaks bones because you have the fibulas here and the tibias here, the medial malleolus. Let me go back. The medial malleolus is here, and the lateral malleolus is here. If you have forced eversion, you're probably going to break this, and definitely it's going to do a lot more damage, tear ligaments. Okay, the sprain is usually inversion or eversion, forced. Okay, and by the way, a sprain results in swelling and ruptured blood vessels, and sounds like a good exam question to me. Okay, there's protraction is bringing that head forward, and retraction is back again. Elevation, depression of that shoulder. Okay, let's talk about stability of synovial joints. The shape of the articular surface helps maintain that stability of that surface. I just mentioned a minute ago that the two bones are usually complementary to each other in shape, though they shouldn't touch because they have that synovial fluid between them, but they will be complementarily shaped. The condyles and epicondyles of those joints should complement each other. So with the meniscus of the knee, it does help with the stability of that joint because it's a little tighter joint, and it does pretty much the tibia and the fibula will articulate a little bit with the meniscus, and so that's a little of an exception where the bones don't touch. There's still a layer of synovial fluid in that knee joint. Ligaments unite bones. It's important in the direction of bone movement, for the direction of the bone movement. It helps prevent undesirable motion. If there is undesirable motion, then there's going to be ligament damage. When ligaments are stretched, they tend to stay stretched, so they don't have elasticity. In common terms, it doesn't have memory. Muscle tone, most important factor. Tendons keep tight with muscle tones. So what does a person do after they've had an injury? They go to rehab, or surgery. They go to rehab. And if they've had injury in that joint and the doctor sends them to rehab, they learn a series of exercises that help with muscle tone, and those tendons help to keep that joint tight and do the job that the ligaments usually do. What happens when a person stops doing those exercises? Well, you usually, a lot of times, the next step is go back to rehab, start the exercises again, or surgery. So muscle tone helps to stabilize the joints. Shoulder joint. It is a ball and socket joint. You had the head of the humerus. There's the head of the humerus right there. There's the humerus. The glenoid cavity, remember our bone parts that we learned in lab. There's the glenoid cavity of the scapula. It is a loose capsule with a lot of bursa. The ligaments prevent displacement of this joint. We don't want to have dislocation of this joint. You have a wide range, probably the most movement of any other joint of the body. Dislocation, I need you to remember this. Dislocation of a joint, displacement of the articular bones of a joint, it occurs when there is forced abduction. Forced abduction. And it's also indicated by displaced articular bones, and the joint will appear deformed. I'm going to repeat that. Dislocation, the displacement of the articular bones of a joint. It occurs when there is forced abduction. It is indicated by displaced articulating bones, which will result in the joint appearing deformed. Now, you do not have to know all the names for lecture or for lab of all these structures, but I do want you to see how many ligaments are responsible. There are many more in the hip, but look at all those ligaments that are holding that rotator cuff together. The elbow joint, it's a hinge joint where you have the trochlea of the humerus, articulates with the trochlear notch, or in the trochlear notch of the ulna. Okay, in lab you had to learn the names of the bones and the parts. There's the trochlear notch that you needed to know, and just by the way, here's a hint that U on that bone tells you U for ulna, that it is the ulna. And telling right or left, this is going to be on the pinky side and the ulna is on the thumb side. Oh, I've got that backwards. Okay, so if you follow your thumb, there's the radius. If you follow the pinky, there's the ulna. So right here, there's going to be the radial notch on the ulna. Wherever that radial notch is, it's going to be on the inside of that elbow. So wherever it is, the right or the left, as you're looking at it, it will tell you right or left ulna. It is a hinge joint, a gliding joint where the head of the radius articulates with the capitum of the humerus. Flexion and extension is allowed with a little bit of gliding. Has many reinforcing ligaments, a stable joint, and there's the olecranon process. Remember, it locks into the back of the elbow. Here's the humerus. It locks in or stops that bone from going any further, so you don't have hyperextension of this joint. This would be bad if you had hyperextension, because that olecranon process sort of locks into the olecranon fossa on the humerus, so it keeps you from hyperextending and tearing those ligaments in that joint. Okay, I'm going to repeat this because I said it wrong and then corrected myself. As you stick your arm out and put your thumb up, follow your thumb, and that is going to be down your forearm, and that's going to be the radius. Follow your pinky down the forearm, and that is going to be the ulna. Lots of ligaments there, and you really don't need to know anything on this slide. Now the hip joint. It is a ball and socket joint. The head of the femur articulates in the acetabulum. Remember, that's that depression of the coxa here, acetabulum. It has a heavy joint capsule, many reinforcing ligaments, many more than that other ball and socket joint, the shoulder. Less freedom of movement than the shoulder, and we talked about that because of all the articulating parts held closely together, more closely together. A heavier joint capsule and many more ligaments than that shoulder joint. And look at, and this doesn't really do it justice, but you have a main ligament that holds that the head of the femur into the acetabulum, and then you have layer upon layer of ligaments that holds that whole joint together. So when a person dislocates their hip, they're going to stretch out those ligaments, and they don't have good memory, so it is probability, the probability of another displacement or placement of that femur dislocation is much greater every time it's done. These get stretched out, and it can happen again. Surgery is probably the best way to fix that, because remember, we just said or we've said before, cartilage and ligaments are avascular, and when tissue's avascular, they don't heal well on their own. The knee joint is the largest, most complex of all the joints in the body. The medial and lateral condyles of the distal end of the femur articulate with the medial and lateral condyles of the proximal end of the tibia. Okay, it is a modified hinge joint, as I mentioned before. It allows for flexion, extension, a little bit of rotation when that orthopedic guy is twisting that knee. Usually it's because you've injured it and it's gonna hurt. Anyway, it's strengthened by many ligaments and tendons. The menisci separates the femur from the tibia, so there is a pad here of fibrocartilage, one of those fibrocartilage pads. And that pad is complementary to the shape of the distal and proximal ends of the femur and the tibia. Okay, and it sort of gives to that meniscus. If you tear the meniscus, going to do a couple of things. It's going to affect the stability of the knee. Also, if you tear, that usually results from the part of that tissue or fibrocartilage floating around in that joint. And what does the body do? There is an immune response to the foreign bodies in that joint. So what does the body do when the immune response kicks in? Let's see, raises the temperature and produces more fluids, sends out the guard, the phagocytes, to try to clean up the joint, and cuts off circulation to that joint when it swells. And that's usually what happens when you tear either some of that articulating cartilage there or parts of that meniscus. And again, it's not going to repair on its own. So they go in a lot of times and suck all the garbage out and then resurface the ligaments, or I'm sorry, the articular cartilage and the meniscus. And it has a heavy bursa. That meniscus, it separates the femur from the tibia, is fibrocartilage that divides this joint into two compartments. Okay, into two compartments. The meniscus divides the joint into two compartments. And here is a cadaver cut so that we can see the parts of the knee. Look at all. This joint is holding up most of the weight of the whole body. And we do have flexion extension with a slight rotation. So we need good stability in this joint. So you're going to have a lot, it's the most complex, a lot of different ligaments. And you've heard of people tearing their ACL, anterior cruciate ligament. There's the anterior cruciate ligament and then the posterior. You don't hear much about tearing that one. This is the most common. And what happens most often is a blow from this direction. Like in football, somebody clipping the player, it can cause a blow from this direction. It forces, and this is usually is what's torn. Lifespan changes, joint stiffness at an early is a sign of aging. Regular exercise can prevent the stiffness. Fibrous joints are first to strengthen over a lifetime. Changes in the symphysis pubis of the vertebral column diminish flexibility and decreased height. So basically, you're going to lose lose or flatten out those fibrocartilage pads between those vertebrae, which causes decreased height. And as a person ages, those vertebrae get closer together, so you have other problems that stem from those vertebrae being too close together, especially if they touch each other. Synovial joints will lose elasticity. Sprains occur. When sprains occur, damage to the cartilage, ligaments, and tendons are associated with this. This is important to remember. It happens by forcefully twisting that joint, and we mentioned that when we were talking about inversion, eversion. Discoloration is due to ruptured blood vessels. Bursitis is inflammation of the bursa, usually from overuse, like tennis elbow is caused by inflammation of that bursa and a slight hyperextension. Tennis elbow is like when you're hitting a forehand with that elbow, you lock that elbow and then you forcefully hit that tennis ball. There may be a slight hyperextension of that joint and stress on the bursa and overuse of that joint, bursitis. Immobilized joint for a long period of time, what happens usually is the hyaline cartilage will degenerate, break down after a period of time. Another thing you have to worry about if a person is immobilized, or even if, they have a joint that's in a cast. Okay, the PowerPoint that I have on Canvas is a little bit different. I added, this was a last minute add to the PowerPoint. I just wanted to talk about these arthritis. Okay, arthritis. There are 3 different types of arthritis. Causes inflamed, swollen, painful joints. Rheumatoid arthritis is an autoimmune disorder. An autoimmune, remember, auto means self. So the immune system actually attacks oneself. An autoimmune disorder. Synovial fluid thickens when the joints become inflamed. The fibrous tissue becomes hardened and ossifies, and this extends to the articular cartilage and causes damage to the joint and makes that joint look disfigured. Osteoarthritis is caused by effects of overuse of the joints and aging, usually aging, and that joint's been used over a long period of time. So gout is the buildup of urate crystals in the joint, causing inflammation from uric acid. And where does uric acid come from? Well, your body produces uric acid naturally when it breaks down purines, and it's usually, uric acid is usually gotten rid of in natural ways, but kidneys, a little bit with the liver and with kidneys, by the kidneys, and sometimes not all the uric acid is processed, so the buildup of uric acid usually results in gout, which is the buildup of those urate crystals that are the uric acid that forms crystals in the joint. And remember, we said in the joint capsule, if there is a foreign object, you're going to have an immune response. Immune response means swelling, inflammation with increased blood flow and pain. And by the way, that pain is from the swelling. And what are some of the foods that would be high in purines? Red meat, a little more than red meat, fish like seafood, your shellfish and fish, bacon, and other types of meat. So a person with gout would be pretty smart to go on more of a vegetarian diet. Alcohol has quite a bit of uric acid in it, and causes more uric acid formation. Okay.